So, so welcome to the Gerontological Society of America Oral Health Interest Group meeting. I just want everyone, please do put yourself on mute during this. If anyone has a challenge with that, we can do that for you as well. Let's see, we have over 30 participants already in. People are still coming in, so I'm going to kind of hold off a couple more seconds before we totally get started. All right. Are we good, Jason?
Yes.
Okay. So everyone double check your status on mute. I got a few people that are still on, and we want to reduce the noise of everyone's pets, etc. So we last met in May. So we are here to talk again about all that's going on in oral health for the aging around the world, honestly. I want to first thank Halion, our sponsor for the Gerontological Society of America, both this interest group meeting and the work group that we have. Do you want to go to the next slide, Karen? I want to give everybody a brief run through our agenda. We do have a 2-hour meeting planned because there is just so much. We were trying to keep it to about an hour and a half, but really want to not only let you know what is going on, which there is a lot, but we also want to hear from all of you. So we are going to have an open forum session. You can see there 2:20 to 2:50. So do take notes while people are speaking about all the topics of things you want to let other people know about, as well as all the things that you all are up to that we want to hear about. So this is going to be interactive at that point. We have a great speakers lined up from 110 to 150. We'll hear from Eva and Eric on value-based oral healthcare surveys. There's a lot, again, that we've been doing, so we will discuss all that's been going on from presentations to papers, etc. We've got an in-person meeting. Yay, we're going to be in person. And we will have actually another oral health interest group meeting there. So we will let you know if you're able to get to Minneapolis, Indianapolis, go to Indiana, not Minnesota. If you can attend the scientific meeting, we've got a number of events going on, so we'll let you know when they are so you can target your time there. And again, we'll then have the open forum, so do please, Debbie, I love your message. Yeah, I'm sorry. Next time we'll plan to be in Minnesota. When's GSA going to Minnesota, Karen? We got to do that. Not in November, it's too cold there. Let's see. So do think of what you want to share. Next slide, Karen. Karen, also, do we want to use the, how do we want to use the chat? If people have questions, I think it would be worth putting that in there as well. So again, not only holding your thoughts till the open forum, but if you have things that you want to talk about, then I think go ahead and put it in the chat and we'll kind of monitor that and we'll make sure that we add you into the discussion when we do the open forum. That would be helpful for the moderators to kind of know what all is out there, what topics we definitely want to make sure we fit in during that time.
Elisa, if you could monitor it and then field the question to the right person, that would be great.
Okay. So I want to introduce our work group. It shows 6 members, but we have a number of other ones. We also have Karen Tracy, who has been working with us just now. She is our GSA guide. Also want to acknowledge Jason Baker, who is on this as well. The two of them are kind of hosting this event. So if you do have any concerns about issues with the whole Zoom process, please direct your questions to Karen and Jason. On our work group also, we have Steve Mason, who is our representative from Halion, which I've been told means strong lion. So for all of those, and that is a new entity that was developed off of, in the past, we were sponsored by GSK, GlaxoSmithKline. So that is their new identity. So we have work group members who are going to be coming in and out throughout this meeting. Dr. Schumann from Minnesota, as well as Zi Chen from Iowa, Michelle Saunders and Z will be leading our open forum time. Bei Wu from New York University, as well as myself from the University of Michigan. Susie, unfortunately, is not able to be with us today. But that is our group that we're going to come in and out. So again, feel free to put stuff in chat if there's things you want to make sure we address. And I am going to pass things over to Steve now, who is going to introduce our speakers.
Thanks, Elisa. It is great to be here. It's great to see so many folks tuned in. This past year, our GSA oral health work group embarked on a major effort to better understand the potential application of value-based care models in oral health care, so we could help identify and clarify possible advantages and disadvantages of this approach. So with support from Haleon, as Lisa mentioned, formerly GlaxoSmithKline Consumer Healthcare, we enlisted the help of Discern Health, which is a consulting firm focusing on quality measurement and innovative payment models in healthcare, to help survey and analyze the landscape of value-based care in oral health care and prepare some reports on this. So to review this project, we invited and are happy to have with us from Discern Health, Eva Lenoir and Eric Wahlstrom, who are going to review their project and their findings for us. Eva and Eric, do you want to take it over?
Absolutely. Thank you, Dr. Schumann, for that introduction. Hi, everyone. My name is Eric Wahlstrom. As Dr. Schumann mentioned, I'm joined today by my colleague, Eva Lenoir. Together, we have both worked on the project and we led the project that we're going to discuss today. This is our 2022 work where we were researching dental providers and dental payer perceptions of value-based oral health care. We'll also describe how this year's project fits into the larger context of the work that we've been doing. We've been focusing specifically on value-based oral health care for a few years now. And I know that some of our work group members and some of GSA members at large have participated in portions of our research to date. So we'll review the broader context of the work we've done. We'll review the current specific work from 2022, and then we'll also forecast a bit of where we're going next and what we plan on focusing on in our future research. So Karen, can we please advance the slides? Thank you. So as a bit of a background, you were introduced to our team. We also have our other team members listed on the slide to give them due credit for all the work they've put in. Brittany Perkins, Nina Reginald, and then Caitlin Esselman, all three of whom are not able to join us today. Also on our research team, we had Karen Tracy. She's been fantastic. She's provided a lot of the thought leadership and shaping of the project, and she's helped us improve our own products, but then also interface with Haleon, formerly GSK Consumer Health. From the Haleon side, we worked with the head of government affairs, Liz Brewer, and Kim Atanazi, the Haleon US North America medical advisor senior scientist. So Karen, can we please advance? So why is Discern thinking about value-based oral health care in older adults? This slide provides a little bit of that background and rationale. As I mentioned earlier, we embarked on this research a few years ago, and we really did that because as a value-based care consulting and policy firm, we've seen through other research and just in our experience and in our field that dental care itself is a high cost access barrier, specifically for adults and seniors. The insurance landscape is kind of wacky. There's not a great way to describe that. You have Medicaid that offers limited coverage of some dental services. and Medicare covers some, but not routine dental care. And then also, as a person ages, out-of-pocket payments for dental care and oral health expenditures also tends to increase.
Yep.
Specifically compared to general populations, that gap has grown. And for older adult populations, these costs have increased at a higher rate even over the past few decades. So in order to help address those cost and access barriers, one solution or one avenue to addressing that is implementing value-based care designs. And the most recent NIDCR report that came out at the end of last year, it had a line in there that talked about how shifting towards value-based care specifically incentivizes providers to improve oral health of the population, decrease coverage gaps, and increases access to care. And so that is we see as as evidence that further supports why we've gone down this road of research. So let's talk about where we've been. So going back to 2020, I think this even started pre-pandemic. And we started by looking at the oral health quality landscape broadly. So when I say quality landscape, I'm referring to not just value-based care, but really all sorts of policies that impact the quality of care that's delivered. And so as part of that, often baked into these quality strategies and landscapes are quality measures. Now, we know that there aren't a lot of quality measures in use in dental care right now. There's a few, and we went and did the research to find what they were and how they were being used. This research right now that we're looking at, by the way, it is from 2020. So those specific numbers and programs in which those measures are used may have changed. Like we might have 11 federal measures instead of 10 now, but really, for a condition as broad, wide-ranging, and impactful as oral health, the number of measures we found just simply isn't sufficient to capture all the processes and outcomes that are involved in delivering quality oral health care. We also found that while there are some measures at the federal level and in use in programs, there are also a number of quality measures that really aren't being taken up at a federal level or even at a state level. And what I'm referring to here are measures that are used perhaps internally within an organization to track quality improvement efforts, or other measures that might be self-developed. You particularly see that in large multi-specialty practices, or perhaps some practices that are integrated between medical and dental. They have a lot of homegrown measures. And the point of bringing that up is that even though we may not see a lot in use, there are concepts floating around, and people are starting to use them and to think about them and to track, their own care that's being delivered. And so we see that this landscape is really at a crucial point where we know there's a need, and there is, some external momentum, but really there's a lot of internal momentum among providers themselves. So let's move on to 2021. And we took our landscape research in 2020, and we wanted to figure out, okay, what can the experts tell us about what's really going on? So we assembled an expert panel to confirm our research from 2020, and then also understand what gaps and opportunities exist to advance value-based oral health care. And lastly, to think through what tactics might be leveraged in order to advance these priorities. So I know that some of you on this call today participated in that expert panel, and we're very grateful for the thought leadership and the expertise that we were able to garner from that. Together, working with our experts, we identified the gaps that are listed and the opportunities that are listed on the left. So we talked about how important it is to define quality and quality measures in oral health care. We talked a lot about pursuing outcomes that are not just perhaps guideline concordant or standard of care, but also that are important to patients, so that patients are progressing towards a trajectory that they feel comfortable with. We talked about some challenges with measurement infrastructure that particularly relates to the use of diagnostic coding. We talked about how we need to see more education and exposure to value-based oral health care in general. And then lastly, we talked about how important it is. Sorry, Karen, can we go back real quick? I got a few more points to make. We talked about how important it was for dental providers themselves to be the standard bearers and the and setting the direction, because I mean, let's face it, providers are the ones that are on the ground and delivering care, and they're interacting with patients. And so we need to look to those experts that are working in practice to carry this movement forward. And then on the right, I have a few prioritized tactics listed here. We discussed many more than this, but these were the ideas that the panel boiled down to and thought that, if we focused on these three areas, then we can really drive, this landscape forward. So one prioritized tactic was leveraging an already existing measure set and measurement organization. So in this case, we talked about ICHOM, the International Consortium for Health Outcomes Measures. They have a standard set of oral health quality measures called the Adult Oral Health Standard Set. And there's an opportunity to work with that organization to further develop patient-centered functional outcome measures. And perhaps, like I mentioned earlier, take some of those concepts that are existing in organizations but don't really have outside backing, and provide that standardization, that institutional support. We also talked about increasing diagnostic coding by dentists and advancing team-based care models. So that's where we've been in 2020 and 2021. But we recognized that going into 2022, there was a need to take what we have learned from the landscape and learned from experts and confirm that even further with the provider and payer community at large. And so that is what our 2022 work is focused on. And Eva is going to walk us through what that research looked like and some of our results. So I think we can move to the next slide, Karen, and Eva, please take over.
Thanks, Eric. So as Eric mentioned, we basically took what we learned during the landscape scan and the convening, and then this year set out to gather insights from dental providers and payers to better understand where we are and the path on this journey towards value-based oral health care. So our 2022 project included, we took a mixed methods approach, so it included a quantitative and a qualitative component. So we developed a survey to get a better understanding of the landscape among dental providers on their knowledge, understanding, participation, and openness to value-based oral health care. And so we gathered responses from 100 dental providers. And then on the other side, we also conducted 15 interviews with both dental providers and payers to better understand the types of value-based initiatives that are currently going on, as well as potential facilitators, barriers, and recommendations to move forward. So our main themes, which we aligned for the survey and interviews, were awareness and engagement with value-based oral health care, medical and dental integration, and interoperability and diagnostic coding. And so these overarching categories probably sound pretty familiar to what Eric was discussing earlier. because these were, identified as a result of the prior work done in 2020 and 2021. And so really the overall goal of the project was to identify strategies and opportunities to increase awareness of and participation in value-based oral health care. Next slide, please, Karen. So over the next few slides, I'll go through the results from the quantitative survey in more detail. So the survey included 9 demographic and background questions and 11 content questions. So we could learn, the types of providers that we were questioning, and then also learn what their perspectives were, their understanding, and things like that. So on this first slide, you'll notice the demographic breakdown of our survey sample. So as I mentioned, we collected responses from 100 participants. Most of these were male between the ages of 45 and 64 and had been practicing dentistry for 21 years or more. Most respondents also identified as white or Caucasian, and there was even representation across the US regions. And then about half of the dentists worked in a solo practice operated by only one dentist and served adult patients. And the majority worked in a suburban setting. And as you can see, this demographic breakdown is largely representative of the current dental workforce. You can see with the ADA data, dental workforce data on the bottom left of the screen. Next slide, please. So one of the key questions we asked respondents was their understanding of how oral health might fit into value-based care. And so one of the reasons we really wanted to know this is because we know that not too many are currently participating in these types of models. This is a relatively newer concept for oral health care. And so we really wanted to know, what is the understanding behind this? And so most dentists reported that their respective dental practice understands how oral health fits into value-based care. That being said, there are still a fair amount of practices that are on that disagree or slightly disagree range. We thought this was interesting, particularly because we know that most people aren't participating in value-based care arrangements. So, but in looking at this graph, we had a few more questions because it's, it's not really telling us, where these dentists that, that fall. So where do solo practices fall? Where do older or younger dentists fall? So next slide, please, Karen. So from there, we stratified by practice type to see if there's differences there. So on this slide, we can see that multi-specialty practices are more likely to agree, and large practices are more likely to strongly agree compared to solo or smaller practices. And so this wasn't too much of a surprise for us. These practices may have larger teams and potentially more resources. And so maybe just more familiar with these types of value-based care arrangements. Next slide, Karen. And so we also looked at this question based on years practicing. And so we know that most dentists that we surveyed have been practicing for 21 years or more, but we wanted to see if there's differences that would indicate perhaps that, dental school curriculums are including content on value-based oral health care, or if there's just differences in general. And so the results here actually surprised us because basically as years of experience increase, so does agreement. And so this was just a bit surprising because those dentists that have, 0 to 5 or 6 to 10 years of experience are just much less likely to agree that they understand how this fits into value-based care. That being said, though, you'll notice that there are very few respondents in that 0 to 5 and 6 to 10 years of experience range. So one thing that we are hoping to do in the future is to better understand, more in that range, what their actual perspectives and experiences are, and if this is in fact actually representative, or if it's just because we didn't have too many people in our survey. Next slide, please, Karen. So another set of questions was around the use of quality measures. So as Eric mentioned earlier, use of quality measures is an essential component of participating in value-based care models. So in looking at this slide, we can see that slightly less than half reported using quality measures. This was not too surprising to us because around a third of dentists reported that they did not have any education on quality measures. We also know that there aren't currently too many quality measures in the oral health care space. So as Eric mentioned from our interviews, we know that a lot of these quality measures are more locally driven, developed and used by specific organizations to gather data and analyze these trends more internally, but they're not really being used or embedded into national activities or requirements. And so here, if we look by practice type, we can see that there's a lot of variation. Multi-specialty and large practices in particular are more likely to use quality measures compared to small practices or solo practices. Next slide, please. And so we also asked about, specific uses for quality measures, since we know that, these can range a lot. Overall, the primary use for was tracking and monitoring quality improvement efforts, followed by establishing and tracking progress toward performance benchmarks. But if we look at practice type, we can see that the larger and multi-specialty practices are more likely to use it for quality improvement purposes, whereas the smaller solo practices are more likely to use it to establish and track progress and things like that. Again, I think this would make sense if you think that larger practices might have more resources and be looking for opportunities for quality improvement initiatives and be able to devote more time and resources in that area. Next slide, please, Karen. And so when we were developing the survey, we anticipated that a fair amount of respondents may not be using quality measures. And so we asked those, among those who are not using quality measures, how many would be interested in using them in the future? And so we can see that basically a lot of them are pretty ambivalent about their use. So there's not too much, really like no interest at all, or not too much very interested. It seems like a lot of people just aren't quite sure. And again, this makes sense if you think back to the fact that about a third of dentists don't have any education on quality measures. Next slide, please. So we also looked at this question in terms of, where do practice types fall? And we see basically, a lot of variation here. We can see that in the stronger or in the least interest, it's mostly solo practices, and that the other types are more towards the middle, with small group practices actually indicating a bit more interest, but overwhelmingly, it's a big range here. So I don't think too many big differences in practice type. Next slide, please, Karen. And so lastly, we asked about medical dental integration because we know that the collaboration between these two fields is so important to overall healthcare, oral healthcare, and successfully advancing value-based oral healthcare. But we also know that medical and dental are trained separately. They're incentivized differently. They communicate differently with different electronic systems. And so, knowing all of these things, we wanted to dig a little deeper to see what actually dental providers perceive as the three main challenges to this type of integration. So overall, it looks like the lack of established models or guidelines was the most selected challenge, which is interesting because it seems, basically the people are asking for just more examples of what this could look like and what success could look like in a medical and dental integrated model. And then lack of collaboration between medical and dental practitioners was ranked as the top challenge among people and the second most reported challenge overall, which makes sense if you think that mostly people are looking for ways and guidelines on how to do this. Next slide, please, Karen. All right, and so basically, what did we learn from doing this survey and these interviews? So on this slide, you'll see our insights based on this research, which does further really reinforce the insights that we had learned earlier on. We just have some more specific perspectives here from the dental payer and dental provider community. And so we learned that basically continuing momentum towards value-based approaches is essential to improve oral health care and outcomes, which we know, and reduce costs, which we know is a big challenge, especially for aging adults, and this can lead to access issues. And so value-based approaches can help to control the cost of oral health care, and they can also increase the emphasis on interdisciplinary collaboration and maximize how oral health care is delivered. Our research also illuminated the need for greater dissemination of educational information from trusted sources of authority. And so this will help to sort of, engage dental providers more and foster greater stakeholder buy-in, which are essential to advance value-based oral health care. And really across the survey responses and the interviews, we learned that continuing dental education and conferences were one of the most reported sources of information on value-based oral health care. And so, this seems like it's a great opportunity to increase the momentum, of education through these specific channels. And then many dentists are currently not being incentivized to participate in quality measurement or other value-based oral healthcare activities. And so engaging this population, would be amplified with consistent incentives that reward providers for keeping their patients healthy, preventing dental disease, and coordinating care for their patients. And that would help to achieve value in oral health care. Also, having payers provide coverage for dental services, would lead to greater engagement in value-based care models, and establishing additional methods for incentivizing provider participation. And another thing that we learned was that, a key challenge really to successfully implementing value-based oral health care is the limited use and exchange of electronic data, because this really hinders the ability to monitor and report on quality measures and outcomes. And so dentistry currently sort of lacks a standardized vocabulary to classify and identify dental diseases. And this was really something that we saw in our interviews, which, a lot of those participants noted that diagnostic codes are not really being used by dental providers or required by dental payers. And so having some formal and continuing education for dentists to standardize use of diagnostic codes and really hone in on their importance for quality measurements and participation in value-based oral healthcare would be beneficial here. And then, while greater emphasis is being placed on oral healthcare, many in the oral health community, don't always recognize the role and importance of value-based care in achieving better oral health care. And part of that is that lack of, education around it really, and the lack of successful models. And so, if medical and dental providers, because they are trained separately and often practice separately, if there is a greater focus on preventive oral health care and integration in primary care, this could have great potential to improve patient outcomes, such as reducing emergency department visits for dental care and hospitalization for primary systemic diseases like diabetes, and reducing those overall healthcare costs. And so I'll turn it over to Eric to provide any additional insights and if there's any questions.
Eric,
Yeah.
I'll put it up so we can be on gallery, so you can see everybody.
Sure. And before we open up for questions, I promised that we would preview where we're going next year, and I intentionally did not build a slide on it because we're still working out the details with our main sponsor, Haleon. But we have a couple ideas about where we're going next year, one of which was called out in the chat. Someone mentioned they hope we repeat the survey with a larger sample size, and we do too. We agree that is something that we need to pursue. And current plan is to pursue an expanded survey of around 1,000 dental providers, specifically oversampling the diverse populations from which we did not garner enough insight on the first round. So women, dental providers with less experience, so in that 0 to 10 years range, and then some of like the racial and ethnographic groups as well. So that's one portion that we need to push that further. And then the other idea that we're setting up is we talked about how there's a need for education. There's a need to understand what's happening and the models that are being used. So we're looking at setting up a pilot study starting in 2023, where we can track some of these key successes that are going on and write case studies about them and explain what they're doing and how that's improving their own outcomes and how they're successfully engaging with VBOHC. And so we've valued, GSA as a partner up to this point in our research, and we are excited to continue moving this forward. And hopefully we'll see each other next year and we can talk about some of the results from the pilot study. But that's summary of what we've done, where we are now, and where we're going. And so Karen, we can open it up for questions at this point.
And Elisa, are you able to moderate that? I didn't see all the Q&A or the questions come in.
There were a number of people that had suggestions. And so Judy Haber, do you want to start by just talking real quickly about your comment on the National Database of Nursing Quality Indicators? Are you there, Judy?
She's there.
I'm here. I may be masquerading as Jessamine,
Yes.
but it's really me. The National Nursing Data Set of Quality Indicators is really put nursing on the map, the nursing profession on the map. And it is largely an inpatient set of indicators, but there are 18 of them. And the point is that there is accountability for quality outcomes related to the nursing care provided, which immediately puts an interprofessional twist on it. But there is no quality indicator for oral health or anything related to oral health. Now, the VA system, and this does apply a lot to older adults, they have an oral hygiene program to prevent NVHAP, non-ventilator hospital-acquired pneumonia. And they are currently negotiating with Press Ganey, which owns the NDNQI data set, to have oral health or oral hygiene become, and pneumonia, NVHAP, become part of the National Quality Indicator Set, which will immediately put oral health, oral hygiene on the map, the national map, in healthcare, overall healthcare. And this would be a huge win, which would then involve another organization that I'm sure you're very familiar with, Eric and Eva, the Joint Commission. And it has already come to their attention, and they already issued a safety alert on it. But anyway, and there are SNOMED terms, electronic data, electronic health record, data, standardized terminology about this. So it's on its way. It is a process. And I will say that to integrate a set of quality metrics into dental care would be a long-term process. Yes. decades perhaps, but hopefully not. But that's what the NDNQI data set is. And it would be very important to work towards that, even if there were only one or two oral health outcome indicators that we could agree on for medicine and medical care and dental care, that would be part of overall health care.
Thank you for adding that additional context. It's very important. And the connection, right? The VA and the Joint Commission, that's unsurprising to us in the policy world, because they tend to be further advanced and pursue these type of opportunities. I know that they focused heavily in the past on mental health issues, and they've exceeded other industry and standards in that area. And so if they're looking to take up oral health, at least in portion as part of this NDNQI set, that's very encouraging.
Well, we're a ways from it.
Yeah, sure. It has to start
At
somewhere,
least
right?
we're on the way with something related to oral health and overall health.
Yeah.
Thomas, do you want to join in this conversation in terms of your question about diagnostic codes? His question was, does anyone have insight as to why diagnostic codes are not deployed? Snowdent, owned by ADA, has been around for years, decades.
Actually, I do. I feel that we're really never going to be able to collect data properly until we have diagnostic codes. Of course, all physicians use ICD codes, and they use multiple diagnostic codes for each procedure. And that allows research to happen, because, why you're doing something can be tracked as well as what's done. I was on the Council on Dental Benefit Programs in the 90s, and Snowdent was ready to be deployed, owned by ADA, but it's been suppressed all these years. And I definitely think it's time. And if not Snowdent, perhaps an ICD code, ICD-10. There are some dental codes in there already for dental treatment, for diagnostic codes, but they're never used. They're never included in commercial billing programs, that are commercially available, practice management programs, I mean to say. So I'm just wondering if anybody has any insight as to why there's such pushback for diagnostic codes in dental. I know initially why, because they really didn't want the data. They were concerned that they would find that things like Crown and Bridge wasn't as necessary.
Right.
I think. But now I think the knowledge base is getting to the point where we just can't keep hiding, and we need to get diagnostic codes out there. So I'd like to hear if anybody else has any comments on that. We really can't move forward with data until we have diagnostic codes.
If I could offer one comment, and I think your comments are right on target, Thomas. But, I think people are, or health professionals, unless they have to be, are afraid of being accountable for the very reason you indicated. But if it can be, as was indicated in your slides, Eva, if there can be incentives provided for at least piloting dental outcome indicators related to diagnostic codes, I think there might be more enthusiasm for it. Right now, I do believe it's viewed as a punishment, not as any kind of reward. So I think it's value-based. There has to be value in it for the clinicians or the owners of the DSOs to want to buy into that kind of a model. And you're right, diagnostic codes are an essential feature of that. So you could start small and grow, but at least start someplace with pilots.
That's a great point. And actually, it's pretty much right in line with what we heard from some of our interviews. We didn't ask necessarily why codes aren't being used. Rather, we asked what would increase their usage, right? And one of the things that we consistently heard was tying financial incentives to it. So I think that's exactly right.
Helene, do you want to talk? You've mentioned in the chat a couple places about the HRSA and OIG oral health measures, as well as then what OSAP.org has to offer. Do you want to share more with the group on that?
Sure. So the OIG is the Office of Inspector General, and I don't know if you want to call it a performance measure, they're different terms and they all end up being basically the same thing. And HRSA, the HIV/AIDS Bureau, and they're really based on a 1-year observation of care. Are certain levels or metrics of care met within a year to show that performance or quality or something has been achieved? And the two are very similar, Office of Inspector General and the HRSA HAB, and you can generally find them on their websites. In 2006, the HIV/AIDS Bureau of HRSA funded an HIV oral health initiative. It was the first one of its kind. It was 6 years and an additional year of evaluation. And I was on the evaluation team, and we expanded the categories that they had of measurements to look at. Was there any indication of, say, a phase 1, maybe even phase 2 dental treatment occurring at these different sites to show that at least basic or routine care was being provided through the government funding? All of that is on the HRSA HIV/AIDS Bureau HAB's website and at Target HIV, which houses a lot of the HIV information. And I think you might find some good information there. We did a study in Massachusetts of our dental patients in our HIV program. And this is not causal, or it's not casual, but it's not causal. And we looked at all of the clients in our area and those that had or did not have dental care in terms of the pillars of measurement with HRSA, like suppressed viral load, retention, and care. We found that all of those that had oral health as part of their healthcare had much higher health outcomes as well. Again, it wasn't designed as the kind of study where you can say, yes, having oral health care caused this person's viral load to drop. And in terms of OSAP, OSAP works very closely with CDC and has looked into hospital-acquired infections for quite some time, and the MMWR that came out about that a couple weeks ago is very critical. So I would just encourage people to take a look at their website. They are the only infection control and exposure prevention dental infection control and exposure prevention society in the world. So it's not like I'm picking one over another. So a little too much info maybe, but does that answer what you wanted?
No, great. It's good to know. Again, this is the goal of this is information dissemination. So we're going to keep going in that direction. Matilda, do you have something real quick? We're going to come back to open forum stuff, but do you want to real quick make a comment? Go ahead.
Yeah, no, I just wanted to share that the hospital inpatient and outpatient dental care from the National Hospital Ambulatory Medical Care Survey, they do provide the emergency visits dental, and it is the only place where you can see diagnostic codes. And I'm going to put in the chat the most recorded primary diagnostic for emergency visit of a non-communicable disease there, no? In the chat, but it's another source where, we can take a look and explore real actions for value based.
So exactly, we encourage anybody, if something else comes to your mind, do put it in the chat, because we, everyone's kind of looking at that, and we'll kind of highlight what's out there as well, so you don't miss it. But yeah, Matilda, if you can put that in the chat, that's awesome. Thank you. And then we are going to move on to our next segment, which is kind of talking about what's been going on that we've been involved in around the country and the world before we kind of get into everyone kind of sharing that. So again, feel free to continue to put stuff in the chat. We'll be monitoring it. Do you want to go to share slides, Karen?
Yep. Right now.
So we'll do the major presentations slide. So we on the work group, those 6 of us that I introduced in the beginning, are heavily involved around the world in terms of promoting oral health for the aging. Just some highlights, actually, not just us, as I said, the GSA staff is an integral component. And in the next one, Karen, Trish D'Antonio, I don't know, I know she was on, I don't know if she's still on here. She, in February, was able to talk to the ASTDD, the Association of State and Territorial Dental Directors. A number of us are part of that Healthy Aging Committee that Lori Cafano runs. And Trish was able to give kind of an update of what's going on policy-wise, and we'll again talk a little bit more about that a little later in the program here. Another big event of the year was finally the Surgeon General report that became the NIDCR Oral Health in America report that came out at the end of 2021. We were able to highlight what was in that report for older adults. If you're not familiar with it, there's actually 2 sections that are kind of applicable. There's both working adults as well as working age and older adults that really have a lot to do with our geriatric population. So definitely, if you haven't yet, take a look at those 2 chapters, which is huge. You know, the first Surgeon General report had some mention of a number of things, but not to the extent which we were able to, Bei Wu and I, and also Lisa Chavez at the NOHC meeting in April. We presented that, as well as Elisa and I presented it to the ASTDD Dental Directors meeting in June. And what came out of that meeting was questions of, okay, great report, now what? And I think those are some of the things, again, if we have a chance in the forum to talk about, there's some things about what should we be doing next. I just got back actually from Geneva, speaking at FDI also at their aging symposium about this report. So really getting it out to the international world about what is going on with oral health in America. Some other areas that we've been working is with AADOCR, CADR annual meeting. They gave the geriatric section keynote presentation. Excuse me. She spoke on improving oral health for persons with cognitive impairment. And we also, Susie, who's not here with us today, she is a actually hygienist and a nurse, a great interdisciplinary collaborator for us. She was at the ADHA meeting in June. And then I know a number of you participated with the ADA symposium, from policy to chairside, improving oral health care for aging populations. So again, Eric was able to present some of this work, as well as Steve. And again, just starting the discussions that we're continuing to have. So that is what is out there in terms of some of the presentations. Bei is going to talk to us a little bit about some of the publications that are new and on the horizon. Go ahead, Bei.
Yeah, thanks, Alice. So just in the next few slides, just want to kind of give you a report on our work group members kind of research activities, and some kind of highlight of these kind of oral health related research for this year. That our group has published a few quite interesting studies related to oral health and health outcomes in older adults across the globe. The first one is a very interesting article that is one of the first to using longitudinal data to examine that oral health in relationship with changes in cognitive impairment among Latino immigrants, longitudinal data. So this paper was published in the JGM, Journal of Gerontology and Medical Sciences. The editor was very interested and wrote the editorial on that paper. Then we have our team look at some social and the behavior characteristics and some intervention studies ongoing. That we have a pilot study was conducted in Singapore, and we reported some pilot results from Singapore. And our protocol paper that is a NIDCR funded U1 grant application that we published that. And our PhD student, Shang Qi, which now he's in the audience, he took a lead on looking at some systematic review on oral health conditions and the COVID-19. So these are the, and also as well as looking at the social isolation, loneliness, and accelerated tooth loss among Chinese older adults, looking at longitudinal data to examine this kind of social isolation as a risk factor for oral health. And we also use the national data from China to look at health behavior. This is one of the only study that published among Chinese population in China. It's an EPI study, large data set, looking at health behavior and tooth retention among older adults in China. This is a finding from the fourth Chinese National Oral Health Survey. So next, I would like to turn this floor to my colleague, Dr. Xi Chen, please.
Okay, next slide, please. Okay, so we published 3 papers in the past few months, and then the first one is to address the end-of-life oral health issue in dental setting, and we often our study found that about 1/3, 1/5 to 1/4 of the nursing home residents die within a year after the new patient exam. And then the vast majority of them don't have a diagnosis for hospice care, or we don't know their hospice care. They just come in together with other patients. So to address that, we develop a prognostic index tool to help a dental professional to identify the nursing home residents in the last year of life. And this was collaborated with Dr. Schumann here in Minnesota. And then the second one was the paper that collaborated with Dr. Wu and her team. It's about the orofacial pain among the Chinese older adult in the last year of life. And finally, we also published a paper regarding the how palliative care patients perceive their oral health and what's their oral health concern, and using a mixed method study here. And so that's what we have.
Okay. Can I just go forward, Elisa? Is that good? Yes, absolutely. Yep, you're up. Okay, good. Our work group has been involved with a couple of national coalitions, actually, and the first one isn't on the slide, and that's the Oral Health Alliance. And that is across age span. And our role was really to make sure that aging was adequately represented in the final information. Both that group and the one that's on the slide, the Consortium for Medically Necessary Oral Health Coverage, participated in CMS listening sessions. And we presented slides and talks, and CMS actually now has their first dental officer. And we presented, and she listened, and she had a couple of assistants, and it was all very good. And then the Consortium for Medically Necessary Oral Health Coverage is very interdisciplinary. And in the CMS listening sessions, the vast majority of speakers on our behalf
were physicians who talked about some surgeons who talked about the need for an expanded oral health coverage in Medicare, and that went over very well. Both groups have developed position papers that have been submitted, and we signed on to those, and that's it in a nutshell.
I think, yep, thanks, Karen. I'll step in. This is Steve again. Yeah, I think the work that GSA and their policy lead, Trish, D'Antonio, and Michelle have been really critical in kind of helping us stay tuned to the evolving stuff in the Medicare realm that we're all concerned about. I just wanted to tell you all, of course, give you a little intro to our GSA 2022 meeting, which is coming up. We're all really excited to get to see each other next month for the first time since probably November of 19. It's going to be November 2nd to the 6th in Indianapolis, not Minneapolis, which was a little cold back in 1989. And maybe that's why we haven't been back here. But we really hope that many of you will be able to join us as well. We wanted to review some of the oral health programming that we're looking forward to. So I'm going to turn things back to Bei Wu from our oral health work group to get that going.
Thanks, Dr. Schumann. Yes, we this year we received quite a few abstracts related to oral health problems and the illnesses. So these are two kind of posters. One is a self-rated oral health satisfaction among older adults receiving one home and community-based service. It's also from Harvard School of Dental Medicine. Another one is from University of Maine. Okay, assessing interprofessional oral health education and practice, facilitation outcomes within long-term care. So this is that their poster time is at the same time on November 3rd, Thursday, from 2 p.m. to 3 p.m. Next, please. Karen, next slide, please.
Do you see it? Emergency department use is the next slide.
Yes.
Oh, sorry. Yes, I was, okay, yes. This one is this emergency department use for dental problems among Medicare fee-for-service older adults in the U.S. is that the first source is from University of Minnesota. It's the same presentation time, November 3rd, from 2 to 3 p.m. But this oral health, the fourth poster, oral health and the mortality among older adults, this paper is going to be on November 5th in the afternoon, Saturday, November 5th from 2 to 3 p.m. So welcome that you can stop by on this poster and talk to the presenters. Next, please. Yeah, so that Steve and I chaired this session, organized the oral health symposium that titled Oral Health and Dental Care Among Older Adults in Diverse Populations. All these presentations and papers use large cohort data, either from the US or from China, or these are overall that kind of we have 5 papers will be presented in this oral health symposium. At the time of the symposium is November 4th, which is Friday, from 4:30 to 6 p.m. And we have Michelle Sanders as a discussant. So that we certainly are going to present some of studies that are hopefully addressing some knowledge gaps using these kind of large cohort studies. After this session, oral health symposium session, we have GSA sponsored interest group meeting. Karen, is that right? So that hope that you all be able to attend, or most of you are able to attend this interest group. So it start that this symposium is from 4:30 to 6. And it's, yeah.
You are correct, Bay. And actually the oral health afternoon starts at 3 o'clock, right before this, and I'll let Steve talk about that. Big
Yes.
afternoon.
Yeah, that's oral health research afternoon. So
Thanks, Bay. Lots of good stuff there to stay tuned for. Each year, GSA also selects a few high interest topics in aging for what we call momentum discussions at the GSA annual scientific meeting. And I'm happy to report that once again, we have one of those devoted to geriatric oral health scheduled at our annual meeting next month in Indianapolis. The topic will be the one listed here, the oral health imperative, intensifying research, expanding interprofessional care, and increasing value and access. And again, we are generously sponsored by Haleon to do this on November 4th. I'm really looking for, I get to moderate this wonderful panel here of experts, including Chris Fox from IDR, ADOCR, Eric Wahlstrom from Discern Health, who you heard earlier today, and our own Elisa Gezi and Michelle Saunders from GSA's Oral Health Work Group. So we're going to be talking at that momentum discussion about these topics, which include the recently released or published NIDCR report on oral health in America, opportunities and controversies, and the application of value-based care models in oral health care. And as you heard about from Eric and Eva earlier today, recent developments in the potential expansion of Medicare coverage for medically necessary oral health care, which Michelle is going to be helping us discuss. And the spring 2023 AODCR meeting, which is actually going to include some special programming on oral health and aging. And we'll also discuss with Chris Fox how GSA members may be involved in that. I'm going to turn things back over to Elisa here to tell us about plans for the Oral Health Interest Group meeting and reception in Indianapolis.
Thanks, Steve. Yeah, so again, if you're able to get to Indianapolis for this meeting, that afternoon of November 4th is going to be big and busy. Starting with a momentum discussion, moving into this Oral Health Interest Group sponsored symposium, and then our meeting. But again, we will feed you so you don't have to figure out how to fit in dinner and all of that. You'll be having dinner with us. 6:30 to 8 o'clock, we will again have both the reception as well as business meeting, giving updates on more of what's been going on, as well as planning for the future. I think if I could decide what we're going to focus on over the next year, I think we're moving into a focus on where are we going with geriatric research? And I think we need to look at that both for what we present at GSA for 2024, 2023, we need to start thinking about that already. And then again, as Steve mentioned, the AAODCR, I'm sorry, I can't remember the acronyms, you guys changed it on me. That meeting, so Jane, you're on. Do you want to give us an update on what's going on regarding that meeting within a meeting that's planned for Portland this coming spring?
So we're still in the early stages of planning it. So we're still contacting a lot of different potential speakers, but we've been talking to people at GSA and a lot of other organizations getting suggestions for speakers. It's going to be what we call a meeting within a meeting, to have an intensive, more in-depth series of talks about a particular topic. We did this last year for the first time about artificial intelligence, and I'm excited that this year it's going to be about aging and oral health. So I hope by December, at the GSA meeting, actually November at the GSA meeting, that we'll have the program pretty much finalized, and Chris Fox will be able to share that. So I hope to see a lot of you in Portland, Oregon in March for this meeting. It's going to be great. And I'm really excited that we're talking about this topic.
And this is where geriatric oral health research, I think, really is at a cusp of kind of redefining itself. In the past, a lot of the researchers were geriatric dental people. We don't have a ton of those people trained anymore, and really are looking into expanding the definition of geriatric oral health research and recruiting those outside of dentistry. And I think also, as I mentioned, that Oral Health in America report, it has a lot of great insight as to kind of what's going on, where are some new directions, and really being able to springboard. Chris Fox was also in Geneva a couple weeks ago, and we were discussing with Judy Jones, just sort of, where is the future of geriatric oral health research heading, and kind of some strategies for doing that. So would love to kind of see some publications coming out of that. So I think there's going to be quite a bit of focus for a number of us looking at this topic over the next year. So any insight you all have into that would be great. I am going to pass the baton now over to Michelle and Z. I know, what is it? A couple of you, Deborah, are from Apple Tree. It'd be great if you guys could also give us an update on kind of what's going on over in Minnesota as well. So this is a chance for people to give updates, but yeah, would love to hear from a number of you. Go ahead, Michelle.
Yeah, thanks. And see, butt in when you think of something good. And what we really do want to hear is what you're doing. And we've heard a little bit from Jane Weintraub, and it would be good to hear from other folks as well. And Stephanie, are you there? Are you on?
Hi.
Yes, there you are. You might want to talk a little bit about your work at CMS. That would be nice.
Well, I cannot say too much right now, but keep your ears open and your eyes open. We're working on a very exciting publication, and it comprises nursing home, oral health, malnutrition, and the overall oral health assessments. So I will let you know once it's published, but we had some interesting findings.
Good. It's nice to know it's in process. Would someone else like to contribute, please?
I just would like to add one more thing.
Sure.
I have been selected by the National Institute on Aging to develop a concept to develop an app for oral health. So we're working on that proof of concept, and I will keep you posted. It's very exciting.
It's very exciting. Thank you.
Thank you.
Okay, someone else, please. Tell us what you're up to. See, are any of your students on?
I know Lori Cafano had to go, and I know she had mentioned before that she wanted me to mention that she runs the ASTDD oral healthy aging work group, and they have been working on for the last couple of years a toolkit that's going to be disseminated to states to help those in aging provide connect them with resources with oral health for the aging. So that, she said, should actually be coming out, released at the end of October. So we're all going to keep our fingers crossed, and GSA will be sharing that as well. So we'll, once ASTD sets that out, we will let you all know, because that's really exciting. It's something they've been working on. A number of us have been working on for a few years.
Yes,
So
I think that's a really good thing to share at our annual meeting and also to include a link to it from the GSA website. So if any of you on this call have programs or publications that you'd like us to highlight on our website, happy to do so. Just send it my way. Or send it to Elisa and she'll get up on the website, right, Elisa?
we connect, we are the best networkers in the world. It'll get there. Jean, what are you posting? Tell us about this video. Don't just tell us the chat.
Well,
Teledentistry.
Teledentistry project that we're doing in North Carolina with our colleagues Access Dental Care, which has been doing mobile dentistry in North Carolina for more than 20 years around the state to long-term care facilities and PACE programs and group homes. And so in this older adult and special healthcare needs populations, we're going to be comparing different measures like urgency of care and treatment needs between on-site dentist recommendations and teledentistry recommendations. So we're still early in the process, but we made this little video to help recruit facilities and patients and tell them a little bit about the study. So it's just like 3 minutes long if you're interested in seeing it.
Great.
Yeah,
And
definitely
Judy,
share.
yeah, Judy, you want to talk about knowyourOQ.com?
I think that's Matilda.
Oh, Matilda, there it is, Matilda.
Yeah.
Sorry.
I'll be. No, thank you, Michelle. In fact, I even have some slides, if that's okay.
The flu shot lady is not gonna be here till 1:40, I guess. Do you guys need anything? I'm done. No? Okay.
Sorry? Can you see my slides?
Yes.
Thank you. So I don't have to go through I will go quickly through the importance of oral health to this group. And that the most common diseases of the world are caries and periodontal disease. But we have a big insight that was to connect oral health to overall health and well-being. And not only inspire on the sources like the Oral Health Report in America, the World Health Organization, and different population with disadvantage. Plus, yesterday being Mental Health Day is also about mental well-being. So Colgate, as a caring, innovating company, reimagining a better future for all, because we do believe that everyone deserves a future they can smile about. We started to prioritize and get serious into the oral health and get action. And the action was to educate and empower people to better understand how their oral health impacts their overall well-being, mental health, and systemic health. And many people know the emotional quotient, the intelligence quotient, and this was the idea behind Know Your OQ. Do you know your oral quotient? And it's basically that, how you link physical and mental to your oral health. I put a link on the website about Know Your OQ. It's really doing very well, and the company has the commitment to elevate oral health awareness for the next 5 years. This is a global company. It is a 10-question free interactive knowledge assessment that leads you to additional information when you don't know about it. And you can, again, receive more information at knowyourq.com. No products, nothing to be sold, but to raise awareness and to connect dental professionals with people. So thank you. Do you have any questions for me?
That's great. Thank you so much. And Steve, I know you wanted to share Minnesota. Unmute yourself.
There we go. Yeah, a couple of things. I put in the chat, we have a new curriculum called Dementia Friendly Dental Practices that is available now through our Minnesota North Star GWEP, our Geriatric Workforce Enhancement Program, and also the area agencies on aging here in Minnesota. We worked in collaboration for the past year or two with the Minnesota Dental Association to craft a curriculum, and we are rolling it out here in Minnesota. It's also available to others, so I've got the link there to give you some materials on that if you're interested in taking a look at what we have. And the other thing, which is another reason I guess I'm glad to be here in Minnesota, is our Minnesota Dental Department of Health Oral Health Program received a $4 million HRSA grant to work on implementation of age-friendly health system principles here for dental practices in Minnesota. And this is actually a big collaboration, so Apple Tree is involved, as well as our School of Dentistry, not just the geriatrics folks here from my program, but also our rural health folks as well, to begin that project. So a couple of big things we're happy about here in Minnesota.
And it was me, Steve, who put you on mute. Sorry.
Okay. Does the next person have something to contribute?
Can I say a few words?
Please.
Yes, right. On behalf of the Geriatric Oral Health Research Group of IADR, and I want to promote our research group here. And as many of you know, that we will have a AAPOCR meeting in the next March. And I will continue to serve as the program chair for the 2023 conference. In the past, we did not have a lot of participation to our group. A lot of abstracts submit to our group. So I think if you have anything that new finding from your research project, please consider submit abstract to the AADOCR and then select the Geriatric Oral Health Research section. And another question I want to I want to ask from the group is that we are looking for a keynote speaker for the next year. Last year we have provide a keynote for our group. So this year we are still looking for keynote speakers. So if you have any suggestion, please let me know. And right. And finally, I have a question for Jan Wenchop. Jan, I don't know whether Linda Slack-Smith has contacted you on behalf of the Geriatric Oral Health Research Group or not, because I think because you are organizing the Oral Health in Aging program, and I think the Geriatric Oral Health Research Group is very interesting in supporting in that effort. So I don't know whether Linda has contacted you or not.
She hasn't contacted me. She may have contacted Chris Fox because we're working closely together to organize it. But I was just thinking, instead of having a keynote speaker for the geriatric group, we're going to have fabulous keynote speakers for the aging symposium. So maybe they can be combined into one
Yeah.
mission.
Okay. So I may be I may follow up with you on that and coordinate this. Is that okay on behalf of our group?
Yeah, and I can share the program with you as soon as we have it finalized.
Okay.
We,
Sure.
we have the first day, which we hope 2 really fabulous speakers from outside of the oral health world. I don't know either of them personally, but I've seen their YouTube videos, and I think they've both written books. One of them is like a bestseller, so I'm hoping, I know one of them has already agreed to participate, and we're talking to the other one later this week. So, and then we want to have a mix of dental and non-dental folks, a mix of basic science and social science, epidemiology, kind of the full range of research method.
Good. Thanks.
Sure.
So I think the ADA is coming up. What's everybody thinking about the meeting and what are they all doing? Matilda?
Yeah, well, we do have as Colgate breakfast symposium on whitening, and it does sounds like whitening and senior. Maybe it's not a popular topic, but it is. So we found a big insight on, people wanted to still show a white smile. And well, if you're attending ADA, it's outside breakfast hours, outside CE hours, and it's our breakfast from 7 to 8 a.m.
On which
Friday,
day?
October 14.
Okay,
Friday, October 14.
thank you. And Susie, we're glad you could get on. That's great. You want to tell us a little bit about the ADHA meeting you attended?
It was held in Indianapolis this year, and it was all about systemic health and the oral connection. And we had a lot of meetings about xerostomia and how that affects the aging. So that's just a kind of a summary.
Great. And Jane, I see you posted that the abstracts are due to AADOCR on October 17th.
That's correct. Coming up really soon.
Yeah.
Yeah, so Jane, is this the symposium deadline is already passed, right? So this deadline is for general abstracts.
For general abstracts for AADOCR,
Yes.
the request for symposium proposals for the IADR meeting in Bogota in June is also coming up soon.
Right. So we have a JDR, Journal of Dental Research, has a special issue that we are in the process. We have this call for manuscripts that are ongoing. The deadline is towards the end of this month. So we hope that we can receive a number of high quality papers related to oral health and aging. So if you have any questions, please feel free to contact me. I'm one of the special issue editor for JDR.
That's right. Thanks for mentioning that, Bay, because that's coming up the end of the month, the deadline for that.
Great. I saw that you have that you're going to submit one. Excellent. Thank you, Jane.
We're working on it.
Great.
What else is happening?
Hi, it's me again, Matilde. But this time talking about the Hispanic Dental Association that has recently created, and in fact, these are the 3 first publications for a journal. So they recently created a journal, and it's the first journal for topics that are related to the Hispanic community, and is in English and Spanish. So I wanted to make this group aware of that additional outlet, even when it's a young outlet, the Hispanic Dental Association. And they are preparing with their research advisory board a white paper publication regarding the status of Hispanics in US. So if you have any contribution, I would recommend to connect with the research department and advisory board, and I can put you in connection with.
All right. Anyone else?
Helene has her hand raised, Michelle.
Oh, okay. Helene, hit us.
Hi. So I think you can tell through some of my comments, my focus is and has been HIV since 1983. Last month, we again celebrated HIV and Aging Awareness Day. But what I've really been working on is for the non-clinical and then for the clinical on the oral health, HIV and aging, and presented on that at our National HIV Over 50 conference in September in Boston. It was broader because it was such a broad audience of peer navigators, case managers, providers and all, but we're wanting to do a second and hopefully offer these as webinars through our AIDS Education Training Center on HIV, oral health, and aging for clinicians. Because what was very interesting, the 3 speakers before me that were all medical were talking about chronic disease, and they were talking about inflammation, the impact of inflammation systemically, and not one mentioned oral health. And then when I got up and started very politely segueing in, because you don't want to lose anyone, the impact of periodontal disease and oral health and the causal, causal, and whatever relationships, I could see them taking notes. So I can just see the much more importance of this interprofessional education because of that. And that's what I've been up to.
Helene, can you hear me? One of my former geriatrics dental fellows set up the first AIDS clinic in San Antonio, and it's been surprising to see the increase in numbers among the elderly.
Who is that? I've spoken at the dental school there before.
Right, but I don't know that she was there. It's been quite a while. She's in Dallas now.
Oh, well, we might just have to email and let me know because it's a very small world.
Yes, it
is. In
is.
HIV oral health.
Okay.
Very, very small. Okay, and I see Jane's got her hand up, so I'm muted.
Okay, Jane.
I just wanted to mention that I just posted in the chat a CNN article that came out this morning about Medicare and dental benefits. So check that out. I think there's a lot of GSA members who are quoted in the article.
Yeah, actually, Michelle, too, there's a question in the chat from Esther Lopez, says she doesn't have a speaker, so she wanted to message that She's interested in that update on Medicare dental benefit. I mean, you talked about our advocacy. Do you want to just say a few words about where things stand now, as far as you know?
Well, I think the important thing to know is that Medicare, actually CMS has some leeway within the broad definition of medically necessary dental care of what they can decide to fund that does not have to be funded by a legislative bill. So they do have a little bit of leeway, and that's something that they're considering. And I guess that's pretty much where we are, unless I'm wrong and Stephanie can tell us otherwise. Oh, thanks, Helene, for putting your email in there. I will give you Carol Ann's full info.
Raquel's been patiently waiting to with her hand raised. Why don't you go ahead, Raquel?
Oh, yeah, please.
It's okay. I can patiently wait. Thank you very much.
It's your turn. Go ahead.
I'm glad to have been here for the last 45 minutes. I was late coming out of clinic, but I am joining from the University of Alabama at Birmingham at the School of Dentistry here at UAB. We have been the recipients, and I'm working with a group of 3 colleagues to actually put together a plan of improved educational, both from the didactic and clinical side, for our students, for our pre-doc students in dentistry, to improve their level of preparedness in dealing with mature adults, and also those with medically complex histories, which is, it's such a presence for us even here at the dental school. But the concern is that we need to branch out, and that we need to really be prepared to reach out to those who are going to be tended to or cared for by our general practitioners. So we're excited at the prospect, but we have a lot ahead that we need to be working on, especially because Alabama is losing dentists to retirement, and we don't have enough dentists to replenish our presence and the services that we need to render in a lot of communities. So urban areas have more dentists than the small towns and rural areas in the state. I know Alabama's not alone, but we have a significant issue here. And I'm actually excited to hear about some of your efforts, and I may actually reach out via email to some of you for maybe a little bit of guidance, so we don't feel so overwhelmed. But we're excited about working actually in a multidisciplinary environment. We're going to work with medicine and nursing in some of these efforts, especially with the primary care medicine program. So we're starting with 3 clinics, and we'll see where that takes us. But thank you for letting me join.
Great. Thank you, Raquel, for coming on. And if you'll note, the research shows, and we're going research all the way back to the 80s that was largely started by the VA, shows that older adults fare much better. Their outcomes are much better when treated by an interdisciplinary care team. So the fact that you're reaching across disciplines is very exciting. And I think that's one of the things that you'll notice as a theme that we've seen throughout this meeting, from the people who are participants to the research papers coming up, as well as the ones that have already been published. We've got a broad, multidisciplinary group of people involved. And as you can see, we've got Judy Haber, who's masquerading as Jessamine Cipollina, and Susie Keeper, who are nurses, as is Bei Wu. And there are other nurses here. Well, that's actually a really good number. So feel free to reach out to folks. Anyone else have something to contribute?
I have one thing to say, Michelle.
Please.
Is the Medicare, Medically Necessary Medicare National Consortium that Michelle and I and Karen and Trish D'Antonio are all part of. If you're interested in reading any of the comments that have been submitted to CMS, and there were over 300 organizations and individuals who submitted, posted commentaries, and these were not one paragraph commentaries. Karen, I don't know if the GSA comments are posted on your website.
I don't know if they are, but I'll check with Trish.
Yeah, that would be great. And I know if any of you are interested in reading those that were submitted by the Santa Fe group, they are on there. It is posted on their website, and it's pretty extensive set of comments. And it's just been great to see the outpouring of support. But I would say one thing, Michelle, is that the most adversarial letter or set of comments posted that I know of were really posted by the AMA. And were very cautionary. They sounded like they were coming from the ADA, actually. So.
What was it cautionary about?
What?
What was it cautionary about?
It was cautionary about CMS using their authority to authorize, and I know that's a little redundant, but using their non-legislative authority to authorize a medically necessary dental benefit.
Yeah,
And
the AMA felt that there would not be enough money to cover all of the medical issues, and that dental would take away from that.
right.
Mhm.
But just so you know, the California Dental Association came up with a strategy, not knowing that AMA would take that position, but anticipating that they would. They came up with a strategy to level the playing field and not make them feel like their pie was being cut by another slice to give to dentistry in terms of reimbursement. So stay tuned. Our consortium is putting together another set of responses to CMS, unsolicited, but they are accepting additional commentaries. We are assembling that and we'll probably submit them next week. And they're being prepared from a variety of talking point perspectives. So stay tuned.
Yeah, I'm curious, just Judy or Michelle, I mean, has ARP or any consumer organization submitted comments? I was struck by the fact that just a few weeks ago, the New York Times ran an article or a review of answering the 6 most common questions about Medicare and the confusion about Medicare. And the number 2 question was about dental coverage and
Right.
how to get dental coverage under Medicare.
Right. Do you want to speak to AARP, Michelle?
No, you go ahead.
Okay, well, they are an interesting group. They have been pretty silent on this. I don't even know if they submitted comments. And what I've been told is they have so many fish that they're trying to fry. They are silently supportive, and they are a member of our consortium. Andrew Schulnick has been an active member, and he has been part of some of the CMS listening sessions that Michelle described earlier. But they have not been proactively engaged. However, Families USA, Justice and Aging, and other consumer advocacy groups have been very involved, particularly Families USA.
Yeah.
Others you want to add, Michelle?
No, that's good. Yeah, I don't know, what we can do, at least AARP, that if they're not contributing actively, they are at least listening. So sooner or later, perhaps they will come out with something.
Judy, do you, what's Santa Fe group up to in this coming year regarding anything oral health, aging beyond the Medicare? Anything else you guys are doing?
Well, the Medicare is pretty consuming, but
Exactly, yeah.
say we do have an initiative that is launching on integrating primary care services in dental settings. And that's being led by Tim Ricks, who you all know. And we are starting that with a series of interprofessional focus groups. And I would say that is a very exciting new initiative that will, I am sure, be a multi-year initiative. And then we are to the point of value-based as a follow-up to our summit in June, which some of you attended. The focus on value-based models of reimbursement, interoperability, and you know, the diagnostic coding and all of that stuff that we spoke about that was so eloquently presented earlier, right on target, will be part of the follow-up to our summit through a combined work group that is focused on that.
Great, thanks for the update.
Great.
Susie, did you want to mention what you were doing? Did she leave?
Are you talking about Susie?
Oh, she left.
Yeah, well, she put a thing in the chat. Her research project has been approved on implementing a dental hygienist on a hospital floor. It will have a qualitative, quantitative, and quality improvement component.
Wow.
Yeah, so that's very exciting. She's getting
Great.
her PhD.
Yeah.
Cool.
I didn't want to, I should have her connect. We actually have our dental hygiene program here at in our school is doing a pilot program in conjunction with our general practice residency over on the hospital too, and bringing students over with faculty to implement hygiene services on the floors too. So,
Excellent. You should definitely talk to her.
yeah, I
and
will put her,
that'd be
get in
great.
touch with her on that. Yep.
Okay, well, our open forum portion has now concluded.
Okay. I just wanted to remind folks, and Karen has put in the chat that this session has been recorded and it will be available, I think, shortly. It may take a few days or so on the GSA website for those who would like to hear it again or take a look, or if there are others you know of who might be interested. I wanted to, first of all, thank Michelle and G for sort of moderating our open forum. I hope you can all tell from our meeting today that GSA has a lot going on oral health and aging, and we plan to continue our efforts to promote the vision of oral health as an essential element of healthy aging. And we are very fortunate to be able to do that in such a robust interprofessional organization as GSA. We hope you'll all continue to stay tuned to what's happening here, and also consider joining us at GSA if you haven't already. I want to thank our interest group conveners, Elisa, Gezi, Beiwu, and Michelle Saunders for their hard work putting things together here. And of course, a special tip of our hats to our guiding light at GSA, Karen Tracy, who is GSA's Vice President of Strategic Alliances and Integrated Communications. She keeps us on track and helps us make things happen, along, of course, with Haleon, which has stood by us for a number of years to support our work. So thanks again to everyone for taking the time to join us today. And we hope to see as many of you as we can next month in Indianapolis. Have a great afternoon, great rest of the week, and everybody take care.
Bye-bye, everybody.
Bye-bye.
Thank you.
All right, I think I'll close it out now, guys.
All right, we'll be in touch on email. Looks great
Yeah.
session.
Nice job. Yeah, it was a long, people
Well,
stay.
it was intricate, but it worked.
Yeah, yeah, it's always great.
Yep.
All right, bye-bye.
Bye-bye.